So, hi everyone, I'm Belinda Stallard, for those that don't know me. I'm a nephrologist. So today I was going to just talk about renal case-based discussions. Happy for it to be interactive. So just a little bit about myself. I studied at JCU in Townsville, and then I did most of my physician training on the Gold Coast, and then went on to do my specialty training at different parts around Australia, including South Australia and Queensland. And I'm now seeing inpatients at both Tweed Hospital and John Flynn Hospital, and that's where my outpatient rooms are at John Flynn. So today we're just going to talk about some cases. Happy for you to speak up and chat about it, otherwise I can just continue on through. Unfortunately, there's not too much new evidence in nephrology to talk about, so SGLT2 inhibitors are probably the only real new kid on the block for us, but so I will mention those, and I'm happy to leave time for questions at the end. So the first case, so you have a new patient to your clinic. They're a 68-year-old man. They've got known type 2 diabetes and they've got a background of hypertension. They're a current smoker and they've also got a history of gout. These are their medications they're on. They're on a calcium channel blocker. They're also on metformin, glycoside and allopurinol. You can see that that's their investigations there. They've got a blood pressure of 157 on 96. They've got a creatinine of 110, their ACR is elevated at about 1.5 grams, and the HbA1c is 7.8%. So, if you were seeing this patient in your clinic, what would things that you would be considering in terms of their management straight away?
Put a shadow on whether metformin and allopurinol are appropriate.
Anything else?
Can you just put the case back up again?
Oh, of course.
I got 68 and diabetic.
No, that's okay. It's pretty early, guys, so happy for just to yell out a few things, otherwise I can keep going. So there's a few things going on. I'll go through. So in anyone who has diabetic kidney disease, the main management targets we're thinking of are obviously controlling their hypoglycemia, improving their blood pressure control, reducing their urine albumin-creatinine excretion, weight loss if appropriate, and smoking cessation. So there's a few things in this patient that we can think about. So just a little bit of background. So diabetic kidney disease is the leading cause of patients to end up on dialysis or with end-stage kidney disease, not only in the US but also in Australia. And this is just some US data. Until recently, we didn't actually have too many trials in terms of evidence of renoprotective agents for diabetic kidney disease or patients with CKD. And these were the pivotal trials many years ago showing that ACE inhibitors or ARBs can reduce worsening of renal function and also cause renoprotective effects. So there was multiple trials, including the Renal trial and the IDNT trial, and these all prove that there's a protection in end organ damage for kidneys. So just a bit of background on how they work. They reduce intraglomerular pressure. They do this by reducing the efferent arterial tone, and therefore we do see that initial reduction in the eGFR and then a stabilisation, and thereby causing reduction in albuminuria and renal protection. So just a little bit back to our patient. So we had a patient, the blood pressure was high at 157 on 96. So talking about blood pressure targets. So our current guidelines say in KDIGO to aim for a blood pressure of 130 on 80 who has diabetes and impaired kidney function. So most of our trials have suggested this. Some other trials have, an American Diabetes Association suggest a blood pressure of 140 on 90, and other trials such as the Renal one that I mentioned before have suggested a systolic blood pressure of less than 140. But in general, I would say go as low as you can, especially if it's a young person who can tolerate a lower blood pressure. Because this is going to have a benefit for them in the long term. Of course, there is the subgroup in cardiovascular disease patients who they've got a higher risk of mortality with a lower blood pressure, so that's something to consider. And of course, you've got to tailor this to patients who are more elderly, and you'd want to not increase their risk of falls or postural symptoms as well. So, of course, always tailoring it, but if they're a young patient with CKD, obviously getting a blood pressure low that they can tolerate is beneficial. Just briefly on dual blockade, I'm sure most of you know that ACE inhibitors and ARBs were trialled together, and there was basically showing that it was quite risky in terms of hyperkalemia, and there was no survival benefit and no benefit in terms of progression of kidney disease. There was a signal that it might reduce macroalbuminemia, but no other kind of benefit. And then in terms of ACE inhibitors and aldosterone inhibition, again, it does reduce albuminuria, but again, there was no improved renal outcomes, and there also is a risk of hyperkalemia. But we still do often do this and just monitor the potassium quite often and make sure it's at a safe level. So, just talking about patients with diabetic kidney disease, I'll talk about advanced kidney disease and end stage just a little bit. So, in this population, they're a bit specific in that they have insulin resistance, but also reduced insulin degradation. But also they have reduced insulin clearance. So these patients often are more liable to hypoglycemia, both on insulin and oral hypoglycemics. We also have to understand the HbA1c is less reliable in patients with CKD because of abnormal red cell population, and then patients on peritoneal dialysis get that obligatory glucose load when they go on the PD bag. So often patients who were on oral agents may have to switch to insulin when they go on to peritoneal dialysis. So this is just talking about some of the tablets that are suitable for advanced CKD. So CKD stage 4 and above, I would generally recommend that you could go on a GLP-1, and this is because they have both kidney and cardiovascular protective benefits. And there's a documented safety in eGFR greater than 15. However, it's important to know that there are significant GI side effects, so this could precipitate an acute kidney injury, and especially if someone already has a CKD4, this is something to consider. The DPP4s are also good in this group, and sulfonylureas. If we're going on to CKD stage 5, not on dialysis, between dialysis and not on dialysis, it's quite similar. Again, the sulfonylureas, linagliptin, or the DPP4s is good. We don't use metformin in this group, and cautious use of GLP-1 because there's not very much evidence in the less than 15 of less than eGFR of 15. And then finally, when you're on dialysis, we do sometimes switch to insulin or keep them on their oral agent if it's appropriate. And again, limited data in GLP-1. And SGLT2 inhibitors I've just mentioned down the bottom again. I'll talk about those more in detail in a moment, but we don't use those in patients who are on dialysis because of the risk, but also the GFR, their effect is usually glomerular filtration of glucose. So SGLT2 inhibitors, they've been a little bit only our kind of new evidence that we've had and something else we can do for our patients with diabetic kidney disease. So they have multiple effects, so in terms of affecting the renal system. So they cause a reduction in intraglomerular pressure similar to our RAS inhibition. They reduce the blood pressure, they have a volume improvement, they reduce albuminuria, and they have multiple other effects that can be help. So this was the pivotal trial Credence, which basically showed that there was patients on canagliflozin had a reduction in the primary outcome, which was worsening renal function or doubling of serum creatinine, and also a mortality benefit. So prior to this, all the trials had been looking as renal as a secondary outcome, but this is the first trial that looked at it as a primary outcome and showed a benefit in these patients. It also showed that canagliflozin had reduced the slope of eGFR decline as well. So, in patients with diabetic CKD, in addition to the ACE inhibitors and ARB, it's very good that we would add an SGLT2 inhibitor. In terms of which groups we would add this in, anybody with an eGFR over 30, I would definitely, there is evidence in CKD stage 4 in this group. I would definitely consider the patient and tailor it to them, because obviously you'd need to know, especially in an elderly patient, whether they're going to stop the medication if they become unwell, because I think sick day management is very key with the SGLT2 inhibitors, because we have seen people come in quite unwell with severe AKIs who are on a diuretic, they're on SGLT2, or they're on an Entresto or an ACE inhibitor, and that's kind of the combination that can cause significant risk. So again, can be used, there's good evidence, but it's just obviously picking and choosing the right patient to use that in. So, non-diabetic kidney disease. So I'll just touch on it, but the DAPA-CKD trial showed that we can actually also use SGLT2 inhibitors in non-diabetic CKD as well. And therefore it's becoming a therapy for patients who don't have diabetes and who have significant CKD or significant albuminuria. So just recently I had a patient who had a secondary FSGS, most likely secondary obesity, and they've got significant albuminuria on a maximum ACE inhibitor. We're putting them on Forxiga now, or dapagliflozin. And unfortunately, it's not currently on the PBS, but it's probably going to go on the PBS soon for this indication. But at the moment, AstraZeneca are doing a program called the Forxiga program, and we're able to enlist them, and they're able to get it for free until it's on the PBS. So just to go back to our case, so this was a 68-year-old man. He didn't have, he was hypertensive. He wasn't on RAS inhibition. His blood pressure was suboptimal. He was overweight. He had abnormal renal function, and he had proteinuria. So we had a lot to do for him. So we could initially start him on RAS inhibition. We could also, not at the same time, because you consider an SGLT2 inhibitor as well. Just a side note, anyone with proteinuria, I always consider other causes. Again, it's very likely this is going to be secondary to diabetic kidney disease, but always someone who's got nephrotic or over a gram of proteinuria you've got to think about myeloma and other causes in this case, especially if they've got other signals like anemia and hypercalcemia. So, in terms of other causes of proteinuria, I just thought I'd touch on. So we've spoken about glomerular proteinuria, specifically diabetic kidney disease. That's also primary and secondary glomerulonephritis. There's other types like tubular proteinuria, which we can see in interstitial nephritis or NSAID use. Overflow proteinuria, which I've mentioned in terms of myeloma, or we can see with myoglobinuria. And then again, post-renal proteinuria, you can see proteinuria in terms of someone who has urinary tract infections. So this is something to consider and always repeat after the urinary tract infection's been treated. I won't touch on this too much, but again, just to note that checking on the dipstick for albuminuria, this only checks albumin. It doesn't actually check all proteins, so it won't pick up those non-albuminuria proteinuria. And also the gold standard for really checking protein is a 24-hour, and this can, because body mass and size can affect the results. Specifically, if someone's got a large muscle mass, they'll have a larger creatinine excretion. They may underestimate proteinuria, and the opposite goes for someone who's got a lower muscle mass who can overestimate proteinuria. Any questions of the case before I move on to the next one?
What did you say, RAS inhibition?
Oh, RAS, or like ACE inhibitors or ARBs, sorry. Or like,
Well, what's RAS bit stand?
renal angiotensin system. I think it just groups both ACE inhibitors and ARBs. It's just easier to say, sorry.
Has everyone else heard that?
No, sorry, it's not on specifically on the case.
No, that's okay.
I've used ACE and ARBs together, and it has been in the past used. Why is it not recommended?
Just because the trials showed that the hyperkalemia was quite significant. I think there are still people who have used it, but they showed that there was no kind of mortality benefit and no benefit in kind of the progression of their CKD in the trials. So I think with the risk of hyperkalemia, they decided, well, it's not worth the risk of doing this together because it didn't actually show a benefit in the long term of doing them together. But there was a reduction in albuminuria, so I think in the right patient it could be considered, but I don't generally do it, but I know some other people do, yeah.
Occasionally too, I see people come with a split dose. I mean, the ARBs and ACE are supposed to be daily, but sometimes I see them come back from specialists and they'll split it to like a twice daily. I don't know, what's the rationale there?
I don't do that, but I'm not sure. Yeah, I guess I can't comment because I don't generally do that, yeah. Well, I'm happy for more questions at the end. I'll keep going through the cases, but happy for questions along the way as well. So the next case, I was just going to talk about severe hypertension. So this is someone I saw recently. She was a 40-year-old female. She came in with a blood pressure of 200 on 110. She was actually initially referred with renal impairment with a creatinine of 137 and an eGFR of 37. She otherwise as well, she was a non-smoker. So what are some things in this case you would consider investigating for, or the possible differentials?
Well, she's quite young to have blood pressure that poor, so you'd be
Yeah,
looking
okay.
at secondary causes.
Correct.
Renal artery stenosis and hormonal causes.
Yeah.
Chronic saturated, all that sort of stuff.
Very good. Very Very good, yes. So these are definitely things you'd think of. So these were the initial tests we did. So looking for any blood or protein as a glomerular cause, looking for aldosterone renin ratio, this was normal. Looking for plasma metanephrines or urinary catecholamines, again, normal in her. She had normal thyroid function. She didn't have any clinical or history features of obstructive sleep apnea and no illicit drug use. So we're left with, as you mentioned, renovascular in this patient. So just to mention some of the secondary causes of hypertension, we've already gone through a few. So they're the endocrine causes we've mentioned. So there's primary renal disease we always need to consider, lots of drugs that can be causative of high blood pressure as well, renovascular, sleep apnea, primary hyperparathyroidism and coarctation of the aorta. So in someone, again, that you mentioned that's young, this is things that in the back of your mind need to consider. So just back to our case. So she was ended up on 4 tablets and she still had refractory hypertension and she also had progressive renal impairment. So we went on to do a CT angiogram which showed this classic string of beans sign with, of the main renal artery. Does anyone know what this is a sign for? Fibromuscular dysplasia. So that's the classic sign on angiogram for fibromuscular dysplasia. So it's the cause of 10% of renal artery stenosis, which is non-atherosclerotic renal artery stenosis. It often affects women who are under the age of 50, and it can be associated with smoking and high blood pressure, but often they have no risk factors at all. As I mentioned, it has this classic beads on a string appearance, which is the contrast filling defects of the aneurysms in the renal artery. And it can affect the distal 2/3 of the renal artery most commonly. Often it has a good prognosis, and I'll talk about renal artery stenosis treatment in a moment, but the treatment is similar in that you would optimise their medical management initially and then consider revascularisation if they, for her, had resistant hypertension on multiple agents and still having ongoing high blood pressure, progressive renal impairment, or if it's renal onset hypertension. So she actually went on to have revascularisation and had improvement. So to talk about atherosclerotic renal artery stenosis, so this is the most common that we'll see. So this is 90% of the lesions we'll see, and it typically involves the proximal third of the renal artery, including the perirenal aorta and ostium. Again, it's usually people who already have cardiovascular risk factors, and it can be a progressive disease with ongoing worsening stenosis. There's multiple ways to diagnose it, but the gold standard is renal angiography. I generally don't recommend a duplex ultrasound because it's not a very good test to check for renal artery stenosis. And I always counsel my patients who come in with severe hypertension and I'm checking for secondary causes is, well, are we going to do something about it if we find it? Are you needing revascularisation? Because if they're managed on medical management and they're not getting severe hypertension, they're not getting worsening renal function, I generally don't screen for it because it's not going to change our management. Obviously, if things are changed, we always have that in the future. Other things to consider is their renal function. So if they do have impaired renal function and you're wanting to reduce their load of contrast, I sometimes can ask my nice radiology colleagues just to go straight for catheter angiography, and this is to reduce double dose of contrast. So this is just saying kind of similar to what I've said, it's the gold standard, and you can just go straight for this test if you're highly suspicious. Otherwise, you can ask your cardiology colleagues to do like a drive-by of the renal arteries if you're concerned if they were getting a coronary angiogram as the other indication, which I've done in a case who came in with flash pulmonary edema. So we were concerned obviously for possibly cardiac causes, but we obviously wanted to exclude the renal arteries as a cause for their presentation as well. So treatment, as I mentioned, it's optimising their risk factors initially, always optimising their blood pressure, and ACE inhibitors and angiotensin receptor blockers are the mainstay for these patients, plus adding in other blood pressure agents as needed. And the only indications really for revascularisation in these renal artery stenosis is if they've got a hemodynamically significant stenosis, so ongoing pulmonary edema, presentations, and you can consider it for people who have severe hypertension, which is difficult to manage, progressive renal function, or hypertension with a unilateral small kidney, which is difficult to manage their blood pressure. And this is just the trials, which I won't go through, which have just all demonstrated. So there was Astral, the Drastic, and the Coral trial, which all just showed that there was no benefit in revascularization over medical management. So just thinking about resistant hypertension in general in this case, so I thought I'd just go through some of the steps that I think about in terms of someone coming in with a high blood pressure that's difficult to manage. So obviously always lifestyle changes and a low salt diet, optimizing their 3-drug regimen, so always ACE inhibitor or ARB initially, potentially a calcium channel blocker and a diuretic. If that's not working and they're still getting ongoing high blood pressure, I often then add in spironolactone, or if you're worried about kind of them becoming dry, you can always swap out the hydrochlorothiazide for the spironolactone, but I think using both together can be very useful. My next step would usually be a beta blocker if they're not already on it for another reason. And then when you get down the lower, things like hydralazine or prazosin or moxonidine, or switching out hydralazine for minoxidil is other options that I consider further down the track. Other things that I also tell patients is to, if they can afford it, buy a home blood pressure machine, because often I find that their blood pressures can be variable throughout the day. If they, obviously doing a 24-hour monitor can also be useful too. But if they can just buy a machine, they can test it for me and they write all the results down. They bring them in and I can have an idea of what their blood pressure is, because otherwise I'm just getting a snapshot of what their blood pressure is when I see them. So just kind of some information on like when to consider a nephrologist. So again, in this patient, she was young, but other patients that would be considerable to be concerned for a nephrology review would be kind of a new or severe onset, difficult to manage, if they have associated renal impairment, because you'd be concerned for a potential GN cause or underlying renal cause for their high blood pressure, if they've got blood or protein, or any clues for a secondary cause. So I'm just moving on to the next case, so I'm happy for questions at the end or now if anyone has any about that case. All right, so this is case 3. So you've got a patient, they've just moved and seen you for the first time, and they've requested a new script for their antihypertensives. They're otherwise pretty well, they've never seen a renal specialist before, no history of diabetes, and they've got no systemic symptoms. They're on perindopril, and you note their blood pressure is 150 on 90, but they're otherwise clinically well, they're euvolemic and no other concerns. You look up and found that they've got some old results from 2012, it's 101 their creatinine, but no other blood since then. So what's your next steps? Do you just give them the script and send them on their way?
That was an old creatinine. You'd rather know what the creatinine is now.
Yeah.
Encourage them.
Yep.
Try and get their blood pressure better under control than that at a 38-year-old.
Yeah. Get them to see the optometrist.
Yep. Anything else?
Yeah, the 24 hours checking anything.
Yeah, protein.
What code syndrome?
Yeah, I think that's good. Yeah, definitely.
Yeah, check the function.
Yeah, so I think initially bloods, checking for their renal function, checking for blood and protein, and considering renal imaging. Usually you could wait for the investigations to come back first before that. These are the results that come back what you've ordered. So their creatinine's a bit higher now, 180. They've got now 1.7 grams of protein in their urine. They've got a small amount of red cells, and their scan shows that they've got small kidneys, and there's cortical thinning. So what are your kind of differentials now that you've got these more of these investigations?
Hypertension-induced nephropathy.
Very good.
Or could be a renal cause.
So what are some renal causes?
Or glomerular.
Yeah, very good. Yeah, I think family history would be important, especially a male, thinking some genetic causes maybe. Alports can sometimes... Yeah. So, I had one more slide, sorry. So you've got a young male, he's hypertensive, he's got blood and protein and progressive renal impairment. So we've gone through most of the differentials. So this patient actually had IgA nephropathy. So he went on to have a kidney biopsy, and this was his immunofluorescence on the bottom right. So it's actually one of the most common primary glomerulonephritis in the developed world. It has this large spectrum of presentation, so it can present with macroscopic hematuria, microscopic hematuria. They can present with a nephrotic syndrome, but they can sometimes present with a rapidly progressive glomerulonephritis as well, so similar to kind of a vasculitic presentation as well. The other classic presentation you might have heard is that synpharyngitic nephritis, which is when they've got a sore throat or an urti, and then they present with hematuria not long after. Classically, they present with less than a gram of protein, but if they picked up late, which often kidney disease can be asymptomatic, they might develop symptoms, present later with already abnormal creatinine and worsening proteinuria, specifically in this case. It is associated with liver cirrhosis, so if patients have liver cirrhosis, they can develop an IgA nephropathy. That can develop in different forms, so just mild hematuria or otherwise some more significant proteinuria as well. And it's diagnosed with a kidney biopsy. So in terms of treatment, it would be similar to what we would do for any patients with CKD and protein. So we want to control the blood pressure, we want to use an ACE inhibitor or ARB. And in terms of specific presentations, we sometimes use immunosuppression. This is generally in the cases that present with that rapidly progressive glomerulonephritis, so patients with like a vasculitic type presentation, and they sometimes have crescents on their biopsies, and they would sometimes get immunosuppression, so prednisolone plus sometimes other immunosuppression on top of that as well. In terms of other things for IgA nephropathy, there are some trials going on now with budesonide. We're still awaiting the results for that, for just that kind of stable progressive CKD. And also SGLT2 inhibitors have got good evidence now with IgA nephropathy as well, so we're adding those in for their treatment plan.
Regardless of their diabetic status?
Yeah, non-diabetic. So yeah, I might have said it in the earlier case, sorry, but yeah, we're using the SGLT2 inhibitors in non-diabetic kidney disease now, and hopefully we'll go on the PBS soon, but we've got a program where we're enrolling them at the moment for treatment. So just back to our patient, what would we do? So as you mentioned before, we'd increase their treatment of their blood pressure, so they're already on maximum perindopril dose, so we'd think about adding in another agent. As I mentioned, the SGLT2 inhibitors, and if they're not already seeing a renal specialist, they would need one, especially with their progressive kidney disease, up to 180. So, case 4. You now have someone who has new renal impairment of unclear cause. So it's a patient who's a regular of your practice. They're pretty well otherwise. You do some routine bloods and their normal renal functions like 65, and you note that it's kind of up to 125 with no other kind of clear cause. They're otherwise well. Their kind of vital signs are normal. What other things, I haven't given you that much information, but what other things would you like to know in this case? Medication, very good, yeah.
Recent infection.
Medical history, family history?
Yeah.
What's changed?
So yeah, their blood pressure's normal. Their urine's pretty unexciting, a bland urine. Their scan is normal, so there's no obstructive cause for their presentation. And they repeat the bloods and, it's still abnormal. The creatinine's a little bit higher again now, it's 140. So you mentioned medication, so you find out a little bit more history that you were away for a little while and the other GP in your practice started the patient on pantoprazole for symptoms of reflux. So I'm not sure if this gives anyone thoughts of the potential cause now. Yeah, very good. So interstitial nephritis. So this can be pantoprazole or PPIs are a common cause of interstitial nephritis. The other common causes are anti-inflammatories. We often see it with penicillin, so flucloxacillin and dicoxacillin are common causes. But there's lots of other classic medications, but these are the commonest ones. So basically it presents sometimes just with a rise in renal function, nothing else, no other symptoms, but they can have a rash, a fever, and they can have eosinophilia on their blood tests as well, but it's not always that I find that. Again, you would look in the urine, it often can be just normal, or sometimes you might see white cell casts. I don't generally check for urinary eosinophils, but some people do. I don't think it's a great test. And then management is doing a kidney biopsy to diagnose it, and then corticosteroids is the treatment. So there's limited data actually in terms of the treatment of interstitial nephritis. Some people are on the belief that it'll just get better on their own. Some people think that needs steroids. I think if you've stopped the offending agent and they still have ongoing inflammation on the kidney, I think it's reasonable to treat because I've seen patients who present late with having been on something that's causing the interstitial nephritis, and they already have significant scarring of their kidney. So we know that if interstitial nephritis is not treated, it can cause scarring and then future renal impairment.
So how long was it stored for? Is it like a time limit?
No, unfortunately there's not a set time because there's not many good, it's not been trialled, but generally 3 months. So usually some people start with 1 milligram per kilogram. I generally just start with 50 or less if they're quite small. And usually 50, I sometimes follow like a bit of the vasculitis program, so 50 for 2 weeks, drop to 40, drop to 30. But if obviously you tailor it, if they're not improving, if they've got side effects to the steroids, you can sometimes, but at least 3 months, maybe quicker, maybe a bit longer. I have sometimes added in mycophenolate or azathioprine if they're not having evidence of improving, and you want to get them off the steroids because of the side effects as well.
And the recheck every 6 weekly for
I think initially quite quickly every 3 weeks, and that's because mainly because of the drugs you're putting them on. You're putting them on like the steroids. You want to make sure they're not getting diabetes, any significant side effects to that, and so generally 3 weeks, and then like span it out from there.
A lot of people have severe GORD, so taking them off the pantoprazole is difficult. Is ranitidine okay?
Yeah, ranitidine and also, but I don't think we can get ranitidine anymore, can we? Yeah, nizatidine I think is what I use now. Yeah, nizatidine. Yeah, yeah. I think.
So you can go straight on to that.
Yeah, I just change them. Well, to be honest, if they come in with PPI causing the AIN, and because you go on steroids, you need them on ulcer prophylaxis, so I generally have to change them to nizatidine and stop the pantoprazole, especially if they've got that. So I just kind of went through some other unexplained causes for creatinine rise that we sometimes might see. So trimethoprim is a very well-known one because it inhibits the tubular secretion of creatinine, but it doesn't actually affect the creatinine clearance. This is reversible, but of note, trimethoprim and Bactrim can also cause an interstitial nephritis, so if it doesn't reverse, it's something to consider. Ranitidine also causes this, but again, we don't use it as often now. It's important to know that some products now a lot of people use can cause a rise in creatinine. So creatine products can cause this. It's usually transitory and it can mimic kidney disease, and it does drop the GFR, but again, I would avoid using creatine in patients who already have impaired kidney function, but if they're healthy patients, it is reversible.
What's that mean?
Creatine, it's like people, yeah, it's not in all protein supplements, but people take like creatine on its own, and it's to help build muscle, yeah, so bodybuilders and yeah. And then on that note, actually patients who just have increased muscle mass, I've been referred patients who are bodybuilders and they have a high creatinine, and again, it's just due to their muscle mass, and then you can confirm this with a 24-hour urinary creatinine clearance just to confirm that it is just based off muscle mass and it's not a underlying kind of sinister cause. So I have one more case, but I was very wary of time. I wanted to leave time for questions. So if you have any questions, I'm happy to go through them now. Any cases you guys have in your, from your GP practice, or we can go through any questions from the cases I went through.
Yeah, I have a case. So
Yeah, of course.
55-year-old Aboriginal man, skinny, homeless, and he presented to the practice for his annual check. He is known to have hypertension, and he was investigated due to a falling eGFR. So a couple of years ago, we were sitting at about 50, and he had an ultrasound that showed bilateral kidney scarring, and then we didn't see him for this period. So he comes back again, and initially his eGFR is around 45, then it dropped to 33 over the space of a couple of weeks. And his blood pressure without medication is sitting at about 160.
Okay.
So he used to be on amlodipine, and he was happy with that, so he kind of kept that. But I don't know why his creatinine is falling. why his kidney function is falling?
Well, we know in our Indigenous population that unfortunately they're a high risk of CKD in general because they're often born with a lower nephron mass. So that is always a risk factor. But if they've got high blood pressure, it could just be related to their high blood pressure. Do they have any protein or anything in their urine? No. I think that's most likely the cause, but again, if they've got scarring, it's suggestive that they might have had some insults over time, might have had recurrent infections or severe episodes of like acute tubular necrosis, so like hypotension or something like that, being unwell. Again, if they've got high blood pressure, I think that's going to be the number one thing, so I'd probably try to manage that a bit tighter if their blood pressures are high. And being Indigenous and already having an EGFR of 35, how old did you say?
55.
So he's probably very high risk for developing progressive CKD. So is he seeing a nephrologist or? I think so, just because we know that they can progress quicker because they often do have the risk factors. And there's lots of evidence that unfortunately they do end up on dialysis a lot quicker than non-Indigenous Australians, and sometimes early intervention can help, but the main thing is going to be blood pressure, and that's probably what all I'm going to be doing is getting the blood pressure low and avoiding anything else. Yeah.
Okay. So he would be on, I think, 5 milligrams of amlodipine.
Yeah, and I'd probably put him on an ACE or ARB as well. Is what I would do. Yeah.
And expect a 10% drop in.
Yeah, exactly. I always see that initial drop, and then I always just say, I'll get a blood test 3 weeks after. If it's kind of an appropriate drop, I'm happy. If it's more than 30%, that's when I consider stopping it and reviewing it. Yeah, that's okay. Anything else?
What's your preferred starting point for new antihypertensives, ACE, ARB, and then once you get to the limit of that drug, do you add the CCB or prefer a diuretic?
I think it depends on the patient. In terms of starting, I have no preferred agent. I just mix it up. I often use irbesartan. I can start at 75, especially in older people, and then up titrate. But also perindopril 2.5 or ramipril, that I just choose a different one. And in terms of the next one, again, I think it depends on their renal function. If you're worried about kind of develops of AKIs, I would start a calcium channel blocker or a diuretic. And I guess if they've got significantly impaired kidney function, I wouldn't think about HCT. I'd more think about furosemide or spironolactone then as well. So that's my general gist. And then generally, if they're still on 3 and their blood pressure is very high, I generally always start spironolactone next. That's my often go-to, because I find that that's definitely always very helpful with severe hypertension.
So do you find it better to go to the maximum of the first agent or to?
I always max the ACE, definitely. Calcium channel blockers, which I'm sure you all find, they get the common side effect of the ankle swelling. So I think, definitely getting that to at least half, like 5 or 10 if it's Xanadip or lercanidipine. And then considering at that point whether you want to go to 20 or just leave it at 10 and then add in a diuretic, but always the maximum of the ACE or ARB, yeah. Only time I'd sometimes cut it down is if they've got later stage CKD and they're getting hyperkalemia, so I sometimes do want to keep them on that RAS inhibition, sorry to use that again. So I would sometimes drop the dose to try and keep them on that, but stop the risk of hyperkalemia. Alrighty. Anything else? Otherwise, I can go through the last case. I just wanted to leave enough time for questions, so it's not a very exciting case, to be honest, so I thought I'd leave it to last.
So sometimes with the ACEs where they're combined with something else, do you ever have the temptation, like, say the maximum perindapril's 10 milligrams, but if you want to put it in a combo, you can only get a 5, 1.25, or,
Yeah.
Do you have the temptation, or sometimes again I've seen the maximum combo and then another 5 milligrams of perindopril added.
Yeah.
So they're actually on 2 perindopril doses.
Oh, as in because it's in the combination drug, it's only 5. Oh, yeah, I have seen that.
So you're actually wanting to give more perindopril than is maximum.
Yeah, I often don't use the combos for that reason, especially when I'm seeing someone for the first time, because I want to switch things up, change things. And then obviously when, they're more stable, that's when you can look at, can we combine any of these? You guys probably think about that more than I do, to be honest, because I often keep them separate. But yeah, I think that's a great plan if it only comes in the 5 and to add in the extra 5 as well.
That's okay.
Yeah, but then if you're doing that, you might as well just use the 10 and a separate,
So
yeah.
it's cheaper, yeah.
Oh, is it cheaper? Okay, yeah.
If you do, only if the combo works out.
Yeah, true, yeah. So I'll talk about the last case. So it was just a patient who has microscopic hematuria, which can sometimes just be routinely picked up. So they were just getting a workplace health checkup, this patient, and all the other kind of investigations were pretty unremarkable. So their full blood count was normal, they didn't have any renal impairment, they didn't have any protein, but you notice their urine, it has 400 red cells. So in this case, what would be your next step?
CT,
Yeah, very good. I didn't have the blood pressure, but I think I'd tell you that on the next slide. So you'd want to know their blood pressure? Yes.
Micro on the red cells, so they upper tract and lower tract.
You just get the urine microscopy and it tells you it's 400, yeah.
Sexual health history.
Yeah, very good. Yeah. So you do it again. So I think it's important to always repeat it because to make sure it's persistent, that's the first step. You want to know their blood pressure, it was normal in this case, and you want to get some kind of renal imaging, whether that's an ultrasound or a CT KUB. And then you kind of want to know a bit more history. Do they have any risk factors? Are they a smoker? And then I think at this point, especially if they don't have any clear renal cause, I think this step would be to consider a urologist initially, especially because you're thinking, is this like lower tract or upper tract to think about? So just to talk about that more, so these are some of the cause of upper collecting system or lower collecting system hematuria. This is from Up to Date. So basically, just some of the things to think about. So when going through kind of your differential for hematuria. Again, this slide's a bit messy, sorry, but this is kind of a good way to think about microscopic hematuria and steps to go through. So is it persistent hematuria? Do they have infection? Do they have concerns for kind of pain with kidney stones? So these are the steps that I go through when I see someone. Again, this didn't come up very well, so I've just gone through and put down the kind of clear points from that. So just some terminology. Macroscopic hematuria is obviously visible to the naked eye. So the screening, that it's not actually recommended to screen for hematuria, so it's they've been shown it doesn't change survival benefit, but if it is picked up, the things that we consider, obviously in the history, is there flank pain, are we considering it a stone, do they have infection? The recommendation if they've got blood is to repeat it in 6 weeks' time to make sure the blood has gone away. If they've got clots, an urgent cystoscopy or a urology investigation. And if they've got obviously an acute kidney injury, if they've got protein, or again, thinking a glomerular cause. If these are all negative, which often I see people come in even just with a small amount of protein, they've had a cystoscopy and it's normal, they don't have any risk factors, their imaging's normal, and you're just left with the fact that they've got ongoing persistent hematuria. This is the group that we would generally class that have probably a mild glomerulopathy, so is things such as thin basement membrane disease or IgA nephropathy. So as I mentioned before, they can present with just microscopic hematuria and otherwise normal renal function. So that was the case in this patient. They had normal imaging. They went on to have, I think, a CT-IVP and a urology review, and everything came back normal. They had no protein, their blood pressure was good, and their blood and kidney function was normal. So then we used to biopsy these patients because back a while ago, and that was because anyone with blood, we would think we should do a biopsy, and that's often what we would find, either thin basement membrane disease or IgA nephropathy. But we generally don't biopsy them anymore, especially because if we don't think it's going to change our management, if they don't have any abnormal renal function, and if they don't have any protein, we often just monitor these patients. So if you see something in your clinic and they've got blood but no kind of glomerular or kind of urological cause, I would recommend every 6 to 12 monthly to do a blood test, because we have been shown that some of these can progress, especially if it is IgA nephropathy. So it's something to just consider, that to always do a 6 monthly blood test and a blood pressure check in these patients. And that was all. So happy to answer any more questions, but thank you everyone. Yes.
I've got a 60-year-old woman who is CKD3, and she has been running along her GFR about 50 with seemingly no problem, but her microalbuminuria started to go up a little bit. So I did a MSU and it showed E. coli. But so I treated that and went away on another MSU, but it didn't change the protein or anything. So, I'm wondering, do I concern about ongoing UTIs, or is that something you need to treat E. coli in that sort of situation?
Oh, so as in like they had protein but no white cells and E. coli, is that what you mean?
Correct, yeah.
Okay. Were they symptomatic?
No.
If they're asymptomatic, I would usually just repeat it, because especially even if they've grown E. coli, and to see if they still are growing the same bug, and if it disappears, which I've often seen that it does, I don't treat it, is generally what I do. If the protein is persistent, I guess consider that it's another cause rather than related to an infection, because you can see a protein rise with infection, but if there's no infection and the protein is persistent, I guess whether it's related to her underlying CKD that's progressing, and then considering the causes of that.
What's the safest antibiotic to use in uncomplicated UTI in an uncomplicated person?
I use Keflex generally, mainly because you do see that rise in creatinine with the trimethoprim. So, and if it just takes that plus a bit of dehydration plus a bit of diuretic, plus I've seen people come in and that just tips them over the edge if they're on the trimethoprim plus they're sick, they're not eating and drinking properly because they're unwell, and that's where we can see that classic presentation of that. Again, it's reversible, but if you can use Keflex and they're not allergic, I think that's a reasonable first option.
I have a 50-year-old female that presented with a 10-year history of intermittent pelvic pain. And all of her, we did initially ultrasound, CT scan, all of that. Everything came back normal except a persistent, she has leukocytes in her urine and no urinary symptoms and no identified pathogen. Where do you go from here?
So just pyuria, but no, okay. And so no drugs that are causing it, because NSAIDs can cause pyuria, and if she's using that for her pelvic pain, I have seen that present like that. Yeah, because so if their renal function's normal, you can just see that kind of elevated related to anti-inflammatories. I have seen that before. Otherwise, I assume a STI screen and things like that would be considered, and then that would be my main initial steps for pyuria. Yeah. But interstitial nephritis can present with pyuria, so I guess drugs, antibiotics. But again, if a renal function's normal, I don't think you'd need to go doing a biopsy. You just kind of see if there's an offending agent and see if it goes away.
So that wouldn't give you the pain, would it?
No, it wouldn't give you the pain, unfortunately. I don't know how to fix that one.
Thank you.
So talking of NSAIDs, they're more and more criminal as time goes past. What's your latest recommendation?
For pain relief?
No, for kidney protection.
Oh, in terms of avoiding NSAIDs, or?
Yeah, well, obviously people need them. So
Yeah.
how long do you suggest people can have them, and what dose is the most current? Because in the past we used to just give them forever.
Yeah.
Give them forever at the highest possible dose.
I think
and now they're more and more vilified, which is fair enough. But I wonder what the latest, because some people are saying not more than 2 weeks, and I get some specialists saying patients, make sure you don't take that more than 1 week.
I think it's always risk and benefit. I think, depending on the patient, how old they are, their renal function, their comorbidities, I think that's always something to consider, because, if they've already got slightly impaired renal function, they've had ulcers in the past, all these things, you're kind of want to not use them for as long. But if they're kind of risk-free and they're just needing it for I would say 1 to 2 weeks, 2 weeks max generally, in a young healthy patient, I don't think that's unreasonable. But I guess, I mean, there are, you probably would see, but like, are there many conditions you would see that would need 2 weeks of anti-inflammatories? Like, would it be like a kind of what's this? Sorry?
Arthritis.
Arthritis, yeah. So that's going to be more than 2 weeks, I guess. So I think it's always just managing risk, and if you are going to put them on for longer, monitoring to see if there's an adverse effect, I think, And the good news is, for often it is reversible if you're not using them for years. We have seen obviously that it can cause damage if it's used persistently for many years, but if it's only for a short period of time, I think it's not unreasonable. Very good. No worries, thank you.